Okay, this lecture is going to be looking at the generic implant design features on a macroscopic level. We've already covered the history of how we've reached modern day implants, and now we're going to be looking at the specifics of their design. So the common implant design features, you've got to consider the macroscopic shape of the implant, the overall size, whether it's got threads or hasn't got threads, the type of implant abutment interface. These are all macroscopic design features. The microscopic design features are to do with the surface topography of the implant and any surface materials. These we will be covering at a later stage in this program. Well, the objective of the design process is to deliver an implant which maximizes the bone to implant contact and has stable long-term results in terms of function and safety to the patient. We also want the surface of the implant at the macroscopic level and the microscopic level to promote osseointegration, that is the attachment of bone. So these are the most important common design features of any implant. We always want to have a design which in some way maximizes the bone to implant contact, and that this bone to implant contact is stable. We don't want the bone running away or resorbing later on because of some design feature. And again, when we come to do an overview of this, we would be discussing features which, although at the time have seemed quite good, have actually promoted bone loss. So we want to achieve an optimal surface morphology for our integration. So when we're looking at the macroscopic features, we look at things like the material the implant is made of and the overall gross design features. We're not looking at the microscopic design features, we're looking at the macroscopic, the gross design, what it looks like. Again, things like the pitch of the thread, depth of the thread, whether it has threads in fact, and the type of implant abutment interface. We're not going to be covering the material in any great detail in this lecture. So, our design, obviously, we've said before, has to somehow promote or be conducive to encouraging the maximum bone to implant contact area. Now, sometimes this is done with things like increasing the diameter of an implant, but of course, when you think about it, threads in themselves will increase the surface area. So the more threads you have on the implant, or the deeper the threads on the implant, obviously the greater the surface area available for osseointegration. Now, some implant designs have very few threads, while others have quite a few threads. And obviously the ones with the maximum threads will present more surface area for bone attachment. However, the more threads you have on an implant, it will mean that you'll have to turn the implant more times to be able to push it through the bone. The macroscopic design features will also affect your surgical protocols. Obviously, if the implant is very cylindrical or an awkward shape, then it might be difficult to insert it into bone. And finally, our macroscopic design features, of course, are going to affect the restorative protocol. Now, the types of modern day implants that are available are the epithelial or mucosal insert, the endodontic implant stabilizer, epiosteal or subperiosteal implant, which we've discovered in the history of implant dentistry, endosteal or endosseous implant, which are the types of implants you're more familiar with, and transosteal or transosseous implant. So we covered the epithelial implant more for interest and to increase our knowledge of implantology. But the intramucosal insert implants are a simple and cost-effective way of retaining a full upper denture. These implants consist of a mushroom-shaped metal implants. They're sometimes made of titanium, but have been made from also stainless steel. The base of the implant, this area here, is inserted into the acrylic of the denture, and this mushroom part will engage the patient's soft tissue. And they're all placed along here, and they've been positioned obviously in areas where there's the deepest amount of soft tissue available for their engagement. Now, the way in which these metal fixtures work to provide retention for your denture is that a small drill hole is made into the soft tissue. The patient has to wear the denture almost continuously, and these mushrooms engage the soft tissue rather like a button engages a vest, or a snap stud engages something. The button engages the soft tissue. If it's not worn for any length of time, obviously the soft tissue will close up. It is quite painful during the healing phase until this tissue becomes keratinized. It's not terribly popular, but it is still used in some parts of the world, and you may come across it. Now, endodontic implant stabilizer is a means of stabilizing root-filled teeth or teeth with reduced bony support. So if one had a tooth that had reduced bone but had a vital nerve, the tooth would first be devitalized and a root canal filling placed, and then these implants, these endodontic implants, used to stabilize the mobile tooth. And these did have quite a high success rate, surprisingly enough. Here's an example of a deciduous E that's been retained for obvious reasons. And what's been done here is these are actually endodontic files that have been pushed through the apex of the tooth and are being used to provide osseous anchorage for the mobile tooth. The only problem with this, of course, is that the opening of the apex has to be in the right position to allow for the instrument to pass through. If the apex opened up in some awkward position, it would be very difficult to perhaps position the implant into bone. Also, you'd end up with an elliptical opening to your apical foramen. If it was high up, you'd have an elliptical opening, which would make it very difficult to seal where the implant was coming through, because again, these endodontic implants do rely on a seal. You can't just have an empty canal. The canal has to be sealed. So the disadvantages are most endodontic failures occur because of this eccentrically placed located foramen, which forms like a teardrop that can't easily be sealed. So eventually you end up with periapical breakdown and failure through periapical disease, periapical infection, because of the inability to be able to seal where the implant is coming through the foramen. Well, we've discussed a little bit about epiosteal or subperiosteal implants. These are placed beneath the periosteum, and they get all their support from resting on the underlying cortex or cortical bone. They can be used in the maxilla and the mandible. People tend to prefer using them in the mandible because of the extra quality of the bone, and again, this is often an area that patients have problems in retaining their dentures. And it's paradoxically, it is recommended to be used for severely resorbed jaws. And this is a paradox because obviously we know that these subperiosteal frameworks and implants, they tend to fail as a result of slow rejection and bone resorption. So one can consider that, if you've already got a severely resorbed jaw, then putting an implant in that will exacerbate that resorption long term may be counterproductive. Right, we move on to our end osseous implant, and this implant is inserted into the bone for support, and it transects just one cortical plate, usually. I mean, there are exceptions to this where you might decide to go through into the sinus or into the floor of the nose, in which case it would be transecting two cortical plates. Now, it may surprise you to know that when it comes to end osseous implants, there are more than just the root-formed implant that you are aware of. There is the plate form implant, which we discussed, the Linkow plates, which Linkow developed, and these are plate type implants. And we also talked, well, we haven't talked about rather, the ramus frame implant. And then, of course, we know the root-formed implants. So, the plate or the blade form implants, surprisingly, because they predate the root-formed implants, have the longest track record. And the blade is inserted into bone. And normally the way this was done is that a high-speed air rotor or cutting instrument, either using a disc or even a tapered burr, long tapered burr, was used to cut a channel through the bone, and then the blade or plate was pushed into the channel and tapped into position using a mallet to push it between the bone and the cortical plates. And as we know from the history of implant dentistry lecture that I gave earlier, these blade form implants do enjoy a certain amount of success and have been successful in the past and are indeed still available on the market and can be used in patients today. Here's a picture showing what these blades look like. This is a fairly standard sort of design. More recently, in the past, they were made of things like cobalt chrome, but now they tend to be made from titanium, and the surfaces have been textured, and there's all sorts of design modifications have been added to try and enhance their integration. The main disadvantage was, apart from eventual loosening of the plate, was often these implants failed because they fractured. Where the abutment meets the blade is a weak area. It can't be cylindrical because obviously the blade is flat. So in that transition from cylindrical to flat shape, there's an area where stresses can focus and build up over a period of time, and they fracture at the neck. Now, the ramus frame implant is quite an unusual type of implant. Again, it's pushed into bone. It's an end osseous implant. It goes through one cortical plate, and its main indication is for severely resorbed mandibles, and it has a tripodal type of design or support. Here's an example of a ramus frame implant, and the anterior part inserts into the mental symphysis, and the posterior wings, if you like, are inserted into the ramus of the mandible. Both of these areas are very good sources of compact cortical bone. So one can imagine that this implant would perhaps have a certain degree of success. And it was designed to support overdentures. It's a typical flat bar. It supports the overdenture rather than retains it, because the overdenture would not derive any support from the bone at all through the fit surface of the denture. the denture would be fully supported by resting on the bar itself. Obviously, by using an overdenture, you have the flanges, which means the patient still enjoys the facial support that flanges would offer. If this case could be fitted with a root-formed implants, the eventual appliance would be very, very bulky, because one can imagine that the teeth might be sitting up here somewhere, and so somehow you have to make up this void with metal and acrylic or whatever, or false teeth, which would be very difficult in a bridge type design. However, with a denture, we can build all this lost tissue up in red acrylic. The transosteal or transosseous implant, sometimes it was called the staple, is a very interesting implant, and it's used in the anterior mandible to support, again, an overdenture. This could be a partial overdenture or a full, a complete denture. And as I say, it's very interesting because this type of implant actually transverses two cortical plates. Transosseous implant, as we can see, it's used in. We don't always have these little additional stabilizing pins. Sometimes they just have a base plate, the screw goes up, and there's another base plate rests on the bone here, and then it supports a bar for the denture. And this type of applier or implant was very popular in the early 80s and late 70s, and did give some good results because, of course, it's going through cortical bone in the anterior mandible, the best place for these type of implants. One of the disadvantages you may have realized is that the way this implant is placed is using an extraoral approach. So one had to cut an access in the chin, just under the chin. An incision was made to expose the inferior border of the mandible, and then the surgeon had to drill up through the mandible and exit in the right place on the ridge. So, there's quite a bit of skill involved in making sure that when you were drilling from extraorally, you were coming up, and that you would in fact eventually end up coming out in the right position on the top of the ridge. So quite a bit of skill in angling your drill. So those of you who started placing root-formed implants will know how difficult it is sometimes to get your angles right. Just imagine trying to drill up through somebody's mandible and get the exit point smack on to support a bar, because this bar, to be any use at all, has to be positioned on top of the ridge, along the ridge. If the bar ended up being too far lingual or being positioned too far labially, obviously it would be absolutely no use in supporting an overdenture. The bar must run along the crest of the ridge, just above the crest of the ridge. If it's angled lingually or angled buccally, the bar can't be used. So again, very, very difficult to actually drill up. These rods here would be some at least 30 millimeters long, so quite long rods going up through the patient, and quite a lot of skill to actually angle that correctly. Nowadays, maybe this is the sort of thing that would really be useful for guided surgery and would be very helpful. Now, we're going to move on to the type of implants designs that you would be more familiar with now, of the endosseous form, because we said endosseous implants can be our blade, they can be the ramus frame, they can be the transosseous type of implant. They all go through bone. And these root-filled implants, or root-formed implants rather, can be cylindrical in design. Here's a cylindrical looking implant. They can be tapered in design. They can be cone-shaped, and there's even a type of implant called basal, which we will discuss in a little while as well. They can have varying lengths of smooth neck, from absolutely no smooth neck to some smooth neck to a lot of smooth neck, to smooth neck that's actually made out of porcelain. This design with the porcelain neck was designed for aesthetic reasons, and was made by, or is still made by, a French company and can be purchased. So we can see a variety of root-formed implants are out there on the market for you to choose from, and they all have different types of interface connection. That is, the way in which the abutment connects to the implant is quite different in all these implant designs. And the protocols used to place these implants is very different. For example, these 3 implants here are designed to be placed in a 2-stage technique at bone level. That is, primarily they're designed to be inserted under the gum and then buried and left a certain amount of months and then uncovered. And the implant abutment interface, which is here on these 2 implants or here, that has to be positioned at or near the crest of the bone. These are sometimes referred to as transmucosal implants or tissue level implants, and this is because the implant abutment interface is designed to be placed level with the soft tissue, or just above the soft tissue. Smooth surface is designed to pass through the soft tissue, and obviously the threaded section is what goes in the bone. These implants, all of these implants are designed to be placed within the bone, and this implant is again probably a sort of hybrid approach where it doesn't exactly protrude out of the bone, out of the gum. It rests somewhere in between bone and the gum level, and again, so it's a sort of semi-submerged place. So these are submerged bone level implants. These are non-submerged tissue level implants, and this is a hybrid type of implant which is mainly going to be used somewhere in between, not level with the tissue and not level with the bone. This area here would be level with the bone. If it were to be sunk into the bone above there, then, as I'll explain in later lectures, these sorts of surfaces, if they're sunk within the bone, will actually cause the bone to resorb, because bone likes to have threads to grab onto. If you don't give the bone any threads, then it tends to go. And these implants here, although they're designed to be placed level with the bone, they do end up losing bone down to the first thread, again, as we will discuss in subsequent lectures. Now, this is an implant design types, and this is a one-piece design. And it's constructed of a solid piece of metal, and they can be used to support teeth and overdentures. You can see here there is no implant abutment interface at all. It has a smooth neck. Obviously, this area is for soft tissue. This area is for bone. One of the things that is difficult to do with a one-piece implant is actually to correct angles. So one can imagine that if you're placing this type of implant in order to support a central incisor, your skills of placement have to be very, very good. You need a template, you need some sort of guidance, because at the end of the day, you're going to be placing a crown on top of this that has to be in alignment with all the other crowns. You're also establishing the emergence profile and the soft tissue contour at the same time as you place it, and that's very difficult to achieve in inexperienced hands, and even in experienced hands, it's still very difficult to achieve a good result. Not impossible, but you need a certain amount of skill and knowledge to be able to use these things. This implant, although it's got some form of angular correction, obviously you need to know where that angle has to be positioned. If you don't position the implant correctly, you might find that that angle, instead of being palatolabally, could be angling, as it is in this picture, mesial and distal, which is no use at all. So when you place these kind of implants, you have to really turn the implant until that angle correction is just where you need it to be for your final restoration. Again, you'd need some sort of diagnostic template showing the eventual position of the crown so that you could make sure that the abutment was in the right place to be restored. So you can think about it as two factors to be considered with these implants. One is the implant has to be placed within bone. You could imagine some sort of template to maximize the positioning in bone. And then you need to ensure that the final position of the post, which is very difficult to change because it's a one-piece implant, that post has to line up optimally within your restoration. So you have to consider two things with these. You have to consider optimal placement in the bone, and you have to consider optimal placement of the restoration for final fitting of the crowns. If you don't get it right, you could end up with a tooth that's too far palatal or too far labial. And this again will have an effect on the soft tissue profile and contour. And we will be discussing this in more detail in subsequent lectures on how this angling position affects soft tissue. And so, as I say, with a one-piece implant, they do require quite a lot of skill in placing them if you're going to restore them at the same time, because you're having to deal with multiple factors. You're having to deal with placing it in optimal bone. You're having to consider that the abutment is going to be in the optimal position for the final restoration. And you've also got to consider the effect that all this might have on the soft tissue aesthetics and margins and emergence profile. So a number of factors to consider. The two-staged implant is far easier in this respect because you're just initially considering where to place the implant in the bone. Later on, any angular incorrections can be compensated for by using some form of customized abutment or angled abutment, which isn't available in the one type of design. This is our two types of design, or two-stage design. The interface is positioned at bone level. Many designs nowadays are favouring some form of hex for restorative stability, and then a long taper again for abutment stability to help stabilise the abutment and reduce abutment loosening. There is a newcomer on the market now which is very popular, where we have a multi-abutment, it's called, or sometimes a uni-abutment. There's all sorts of names for these, and what it consists of is a screw-in abutment, and then on top of that another bolt screws on another piece of apparatus onto the top of that. So you can see this is an extra level of screws, it is an extra level of complexity, it is an extra level of area where things can go wrong. It is another interface, because you have an interface here and you have an interface there, so you're doubling up on your interfaces, you're doubling up on areas of potential weakness. Now, or another way that they sometimes sort of explain this this pyramidal effect is that you're stacking. You're stacking one thing onto another thing, onto another thing. And that's not bad, but the more joints and the more stacking and the more screws, the more interface, the more things that can go wrong. So if this came back loose as an appliance, well, is it this area that's gone loose? Is it the abutment that's got loose? It's very difficult to distinguish and diagnose where the problem lies. In this sort of approach, if something goes loose, it can only be in one area. So that's not to say that this type of stacking arrangement or three-piece design, not to say it's bad, because there's no wonderful design in implant dentistry. They all have their advantages and their disadvantages. You just have to be sure that you can manage any complications that may arise as a result of design features, and that you can identify them and you can competently intercede and correct them. So again, these are two-part systems. This is a three-part because it has a bit on top. This kind of approach might be seen on the all-on-4, where the distal-most implants in the 4 or 5 region tend to be angled at about 45 degrees. So you end up with a special abutment that's got an angle in it to correct at 45 degrees. And again, as we go through the course, you will see these abutments. We will probably use these abutments on the OsteoTie system. As yet, none of you have been introduced to them because we're still just going through the very, very early stages of implantology. And we haven't really discussed too much on restorative protocols. So just to recap, two-stage implant, you have the threaded section, and the top of the threaded section is often referred to as the platform. And that's the bit where the abutment rests or joins the implant. So there's our second part, which is the abutment. That's normally smooth. It passes through the soft tissue. And the joint between, or the way in which the abutment connects to the implant, is called the implant abutment interface. So we have the platform, which is the top of the implant, the area where the abutment connects, but the actual design and where the gap is between the abutment and the implant is called the implant abutment interface. And that interface is very important in maintaining soft tissue and bone levels. And again, in another lecture, we'll be discussing about implant abutment interfaces. A one-piece implant, one of its big advantages, of course, is because it's solid, it has no implant abutment interface. You will only have an implant abutment interface on a two-stage system. If we compare the sort of differences between our tooth and our implant, there is a great variety of difference between the two systems. And again, these differences will be highlighted in subsequent lectures, in that we will be dealing in particular about the soft tissue interface and this area here where the implant penetrates the soft tissues and mucosa to enter the mouth, because the biology of this region here is very, very interesting, very, very complex, and the biology in this region is affected greatly by the type of implant abutment interface and by the type of platform. And we will be discussing things that you might have heard about, such as platform switching, which has been designed to try and stabilize this soft tissue implant interface, because this tends to shrink away. Many people get concerned about the bone, but the soft tissue is just important for health and aesthetics. And an implant can be well integrated, but can fail because the patient is unhappy with the soft tissue aesthetics and appearance. And those of you that come to the surgery will no doubt see at some stage or other patients coming in with soft tissue issues, with unhappy about the aesthetics of the pink tissues, not just the hard white tissues, but the soft pink tissues patients are concerned with. So as I mentioned before, the positioning of the implant abutment interface can vary depending on the approach. We have a submerged approach where the implant is placed under the soft tissue. In this situation, the implant has been placed at bone level. We have a non-submerged approach where the implant interface on a two-stage implant is actually at the soft tissue level. It's not really possible, when you think about it, it is not possible to use a one-staged implant in a submerged technique. It is not designed for a submerged technique. A one-staged implant does not have any platform. A one-staged implant does not have an implant abutment interface. These are all characteristics reserved for the two-piece design, not the one-piece design of implant. So remember, we have a submerged approach, a non-submerged approach, and that's relating to the positioning of the implant abutment interface primarily. So this is submerged and non-submerged. Superimposed on this is the idea of a one-stage placement or a two-stage placement. Obviously, this implant here is designed primarily for a non-submerged one-stage placement. Because it's coming through the soft tissue, it doesn't need to be exposed, so it's a one-stage protocol. This, because it's been designed for the implant abutment interface to be positioned at the bone level and used in a submerged approach, the soft tissues will grow over the top, and it will be necessary to use a two-stage or a second stage to uncover. So these two-staged submerged implants require a second surgical procedure. These one-stage non-submerged implants require only one surgical procedure. And of course, the people and the manufacturers that sell these implants will point to the fact, well, this is saving you time and your patient doesn't have to have another surgical procedure. And that is absolutely correct. However, to be able to do a non-submerged approach, you have to have a number of other factors in place, like excellent primary stability, good oral hygiene, healthy patient, no occlusal problems. So you have to be careful, not one size, not one protocol fits every situation. In the submerged approach, it's a lot safer in that you don't need to worry so much in the early stages about the occlusion. It's buried, it's out of the way. And of course, having the implant submerged means that any angular correction can take place within the soft tissue quite low down. This type of approach, any angled abutment will start to correct quite high up. And again, we will talk about how the design of the implant affects the restorative flexibility in later lectures. As I said at the beginning of this thing, you can look at materials and design. And the design, one of the things it will affect is not only the amount of bone interface, but it will also affect the restorative protocol and the surgical protocol. So we can see this design of implant means the surgical protocol is only one stage and it's a transmucosal non-submerged. This type of implant, two types of operation, and it's a submerged approach. This angular correction is far more difficult to achieve. The aesthetics are far more difficult to manage in the anterior mandible and maxilla, because you can imagine you could be showing metal. This is easier to manage angular correction and less likely to show metal. So we can see how the design affects the surgical protocol and the restorative protocol. And again, in subsequent lectures, we'll be going into this in far more detail, but you can, if you wish, read around it in the interim just to get your head around things. So if we compare the one stage, the two piece, the one piece can only be placed using a non-submerged placement protocol. This two piece can be placed using a non-submerged or, believe it or not, a submerged placement protocol, depending on where you place the implant abutment interface, either at bone level or at tissue level. One stage can only be used, sorry, one piece, remember one stage, can only be used in a one stage technique. A two-piece implant can be used a one-stage or two-stage approach. If you wanted to use a two-stage approach with a two-piece implant, or sorry, a one-staged approach with a two-piece implant, the easiest way to do that is to place the implant and then to place a healing abutment. This means that the implant abutment interface is positioned at bone level. However, an abutment or a healing abutment is used to keep the soft tissues apart and to allow soft tissue healing. So now it's being used in a one-stage protocol in a non-submerged technique, even though the implant abutment interface is level with the bone. And this has advantages and disadvantages in that you can obviously avoid a second surgical procedure. The disadvantage is that now you have to consider things like emergence profile and protecting that implant whilst it's osseointegrating. Obviously, a one-staged implant, because it's in the mouth from the beginning, is subject to loading or immediate loading straight away. Even if you keep the restoration out of the occlusion, there's going to be some sort of loading occurring on that implant. The only way you can avoid loading is to remove one of the patient's jaws, and then you will successfully have an unloaded implant. Otherwise, there's problems with that. Two-staged implants or two-piece implants, they can be loaded immediately if you place them and then you fit an abutment and you fit a crown. Or you can do delayed loading, again, because you're placing them at bone level, covering them up. They're not in the occlusion, they're not in the oral environment, they are not being loaded. So again, you can delay the loading on a two-stage, or you can have immediate loading. But on a one-piece, it's a one-stage placement, transmucosal implant, it will be loaded. A one-piece implant does not allow any angular correction or correction of the emergence profile. So the tissue contour is often defined entirely by the shape of the abutment that's given you, whereas when you use a two-stage approach, you can have a far wider variety of angular correction, and you can design the abutment to actually support and promote a good emergence profile and margin around the tooth, which is a lot more difficult to achieve with a one-piece implant. Now we're going to look at the this type of implant is called a basal implant. It's a one-piece implant and it's designed in situations where there's very little bone, and we can compare it to our two-stage implant. Now, this diagram shows an implant that's being designed for a non-submerged approach for a one-stage surgical protocol, and this implant has actually been buried into the bone. If this would happen in real life, the bone would drop down the first thread because these polished necks will not maintain bone. The same way, this will not maintain bone either. We can see how it's been designed to bypass the nerve, and this would be in a situation where you might have very little bone above the ID nerve, and so you want to actually transverse the ID nerve and miss it altogether. These basal implants are designed to engage basal bone or cortical bone. So you can see we have bicortical fixation, which is fixation at the one cortical plate and then fixation in the other cortical plate. This implant can only give us unicortical fixation because it's not engaging another cortical plate. The ID nerve is preventing that. Also, the design of this implant, because it has no threads, it's not actually engaging the cortical bone. So it's very doubtful how much benefit is designed by placing a smooth neck into cortical bone, because you get no primary fixation without the presence of threads. So we can use our implant and we compare the crestal and the basal placement type of protocols. You have an implant which goes through one cortical plate, then it's in the less dense bone, and then as it goes slightly deeper, you might be fortunate and find that lower down the bone starts to become a little bit dense. The cortical plates become a little less cancellous and more bony as you approach the inferior cortical plate or the basal bone. So you'll find, especially in the mandible, you might drill through the outer cortical plate, and then you'll hit cancellous bone and it will go very, very soft, and then it will start to densen up again as it approaches the basal bone. And in the mandible, we can imagine that you have the alveolar bone that is sitting on top of the basal bone of the mandible. So you'll get this gradation of drilling feelings, very, very dense, then quite soft, then it'll start to densen up again. And this type of fixation goes all the way through all bone types. You've got engagement in one cortical plate through the less dense trabecular bone, and then you start to engage the cortical bone of the basal bone cortex. I would like or prefer to see threads the whole way up, because as we'll talk about in further lectures, this kind of smooth surface does not actually hold on to bone or encourage osseointegration. It's useful to have a good length, a range of implant lengths, because ideally one likes to try and get as close to or engage the other cortical plate to get what we call bicortical fixation. That's a feature that is considered very important for the success of implants, that you have them in two cortical plates, not just resting in thin air in cancellous bone. That's not to say they don't work, but ideally we'd like to see them in two cortical plates, and that's why in the posterior maxilla I often do not mind drilling through to the sinus, because I want to engage that cortical plate. Floor of the nose, I want to engage the cortical bone in the floor of the nose. And those of you who see us placing implants realize that we do go quite high looking for that basal bone. Now, there's various designs of basal implants. Our one-stage implant is a sort of a basal bone implant. And there's also these types of design here, which are examples of basal bone implants. These implants are used today in all parts of the world. They do give good results, especially where you have a very resorbed maxilla or mandible. Especially the maxilla. So if you have no maxillary bone left, then these implants may offer your patients some sort of restorative stability. There is some question now as to how stable long-term grafts are, especially autogenous bone, and so there is more renewed interest in trying to make the best of the patient's own bone and positioning the implants where the bone is, rather than trying to build bone where there isn't bone, where it might not be stable long term. So again, a lot of things to consider.